Okay, role of imaging in lung cancer staging is the topic of my presentation. Two learning objectives. One is to understand the role of diagnostic imaging in the pretreatment clinical staging of bronchogenic carcinomas of the lung. And then we're also to understand the capabilities and limitations of thoracic CT and PET CT in the TNM staging system for lung cancer. So why do clinical staging for lung cancer? Well, purpose really twofold. Well, onefold, two possible options. One is curative. Is a patient a candidate for surgical resection of the lesion or potentially definitive radiation therapy versus palliative therapy for more advanced stage disease? So TNM staging system for lung cancer, originally proposed by Dr. Clifton Mountain in the early 70s, adopted by the American Joint Committee on Cancer in 1974, has had multiple revisions over the ensuing decades, and then most recently in 2009, a more updated version was published, and in this really to better differentiate tumors with different prognoses. So we'll sort of touch a little bit on that. Now this slide I've included in the CD. I'm not going to really read this slide to you, but we will hit on some of the important changes in the T and M staging and give you some imaging examples for that. Okay, so in terms of actually what imaging do we utilize? Well, if you look at ACR appropriateness criteria, actually both, and what I'm going to talk about, both have a rating of 9, but CT chest without contrast through the adrenal glands has the highest appropriate rating. One of the nice things about not using contrast is the fact that you can actually classify lipid-rich adrenal adenomas as such. The other would be, the concern is, can we see liver lesions? Well, most often you can adjust the windows and you're able to see that. So CT chest without contrast is good. Also good, obviously, is CT chest with contrast, again, through the adrenals. So there's really not any great scientific evidence to support the use of IV contrast. Certainly it makes it look better. It's easier to see things, so we feel it improves evaluation of the mediastinum and the liver. And use really ends up being based on radiologist preference and also, obviously, patient factors. And then also in staging would be FDG PET, skull base through mid-thigh. In terms of important imaging evaluation of the primary tumor, so important things with regard to the T-stage. T-stage really more anatomic, things that we're looking at. So the anatomic location, obviously where in the lungs it is, how big is it, is there invasion of chest wall, the mediastinum, or even vertebrae? And then also, are there other nodules either in, at least for the T-stage, the same lobe or in the same lung but a different lobe? And we'll go through that as well. Okay, so with regard to imaging the primary tumor, again, because the assessment of it is really primarily anatomic for things that we're looking at, CT is going to be the primary modality. MRI is also can be used, but really more in a problem-solving role, superior to CT for detecting neural foraminal involvement into the spinal canal, as well as brachial plexus and superior sulcus tumors. Role of PET is really limited in the T stage. It can be useful in differentiating mass from surrounding lung, particularly if you had a non-contrast study. Let's kind of go briefly through this, but new TNM staging system, T factor changed where T1 is subclassified by size, T1A is less than 2 cms, 1B would be 2 to 3. T2 is also subclassified into 2A, 3 to 5, 2B, 5 to 7. And then T2 lesions greater than 7 reclassified as T7 centimeters, reclassified as T3. And also reclassification of T4 tumors by additional nodules in the primary lobe, so same lobe as T3. And then M1, reclassification of tumor with additional nodules in the ipsilateral lung, different lobe as T4. So here's an example of an ipsilateral nodule in the same lobe. So this is the left lower lobe primary. This nodule is in the same lobe. If this is a metastatic nodule, this one is classified as T3. Ipsilateral lung, same lobe, T3. Different patient with a right upper lobe mass here has a nodule in the same lung, so ipsilateral lung, different lobe. This would be classified as T4 if this is a metastatic nodule. Also, in terms of the T tumor, looking at chest wall invasion, CT reported sensitivities and specificities. If you sort of look at various studies that have been done, pretty broad range going from 38 to 87 for sensitivity, specificity 40 to 90. MR is really not any better. Pleural reaction inflammation can mimic chest wall invasion, so it's pretty subtle, or can be subtle chest wall invasion can be difficult to detect imaging-wise. And then the other is most reliable indicator, which is sort of like saying, you know, it's a sunny day if you see the sun. Well, you know if there's definite bone destruction with or without chest wall or mass extending in the chest wall, then it is chest wall invasion. So here's an example of a mass in the right lower lobe. See some increased density in the chest wall. Really don't know whether this is microscopic invasion or simply just reaction up next to it. This case here illustrates more definitive T3 chest wall invasion because there's definite rib destruction you can see here in the overlying ribs. In terms of mediastinal invasion, minimal involvement of mediastinal fat can be considered resectable. Tumor invasion of vessels, the trachea, esophagus, vertebral bodies, obviously is going to preclude surgical resection. And here CT and MR are really pretty comparable. Some criteria that you can utilize if a lesion, at least based on imaging, is surgically resectable would include less than 3 centimeters of contact with the mediastinum, less than 90 degrees of contact with the aorta, so about 1/4 of the circumference of the aorta. And then if you see a visible fat plane between the mass and adjacent mediastinal structures. So example here of a lesion that would be considered surgically resectable, just contacts the aorta, sort of get a subtle hint of some a fat plane between there, and this was indeed resectable. This lesion, not surgically resectable, at least not for cure, certainly for palliative treatment potentially, but this left upper lobe mass here directly invaded the vertebral body and into the spinal canal. In the TNM staging system, the N factor, no changes were made. Nodal involvement classified as N1, N2, or N3 based on location relative to the primary tumor. So N0 would be no nodal disease. N1, nodal disease in ipsilateral intrapulmonary, peribronchial, or hilar lymph nodes. N2, nodal disease in ipsilateral mediastinum and subcarinal lymph nodes. And then N3, distant nodal disease in supraclavicular lymph node zone, as well as contralateral hilum or mediastinum. So on this CT example here, have a left lower lobe primary mass. There is an enlarged lymph node in the ipsilateral hilum and in the subcarinal area, so N1 and N2. A CT for hilar nodal disease, relatively low sensitivity, relatively high negative predictive value though, so not seeing lymph nodes. You can be fairly confident that there are not any nodal metastatic disease in the hyla. With CT mediastinal lymph nodes, a little easier to detect, better sensitivity and specificity around 80%. So CT being an anatomic imaging modality, at least how we utilize it, size greater than 1 centimeter is the main criteria that we're using. A couple features you can use to sort of help you would be central fat density in the lymph node. Sort of the fatty hilum would suggest benignity, where central low density in a lymph node suggests necrosis and malignancy. So here's an example of enlarged right paratracheal lymph node, greater than 1 centimeter short axis, and this was indeed nodal metastatic disease. These examples illustrate, fatty hilum here. It's relatively prominent lymph node, but is benign. Over here on the left, you can actually see the endobronchial lesion, but this subcarinal lymph node, very heterogeneous, not fat, necrosis, malignant. A PET is better than CT in that it has a sensitivity of about 79% compared to 62, specificity 91 compared to 73. And one of the nice things about PET is it is more specific than CT in identifying tumor in normal-sized lymph nodes and also in differentiating benign lymph nodes from nodal metastases. And then, as I'm sure we'll hear in the next talk, staging accuracy is improved through the use of integrated PET-CT compared with CT and PET alone. So example here, actually a relatively small nodule in the right lower lobe. Lymph nodes in the subcarinal and interlobar region on the left hilum, less than 1 centimeter, so anatomically considered benign. But on PET, you have, obviously, the lesion is positive in the right lower lobe, but there's also positivity of the N2 and then the contralateral N3 lymph node. Another example for PET with nodal disease, left upper lobe primary lesion here. There is an enlarged, at least borderline enlarged, based on size, left scaling lymph node, and that is indeed PET positive as well and represented N3 nodal disease. And lastly, just cover a little bit on imaging of metastases. Distant mets reported in up to 21% of patients with non-small cell lung cancer. Common sites, obviously going to include adrenal gland, the liver, usually going to be multiple, bone as well, and then brain, and brain is usually, or at least often, isolated. Okay, because of this, staging CT includes through the adrenal glands. Because of the multiplicity of liver lesions, adrenal glands usually sufficient. In the new TNM staging system, some changes were made here with regard to the M factor. M1A is now used to describe pleural and pericardial metastases. M1A also used to describe metastatic pulmonary nodules in the contralateral lung. And then M1B would be distant metastatic disease. In terms of identifying malignant effusion on CT, classic finding would be soft tissue nodularity, not always present though, and also fissural thickening. PET is superior to CT in terms of imaging confirmation of a malignant effusion. Example here of pretty obvious pleural thickening. On the right, this would be considered M1A, pleural metastatic disease. In this case, we have a PET positive left upper lobe mass, and you can also see a pleural-based nodule here on the left, very small, that is PET positive, also represents M1A, pleural metastatic disease. It's actually the same case I showed you a little bit earlier with the left lower lobe primary that has the T3 nodule in the same lobe, but there's also another nodule in the right lower lobe, so contralateral lung classified as M1A metastatic disease. Sort of classic metastatic disease here, right upper lobe primary, lesions in the liver, lesions in the adrenal gland, these are considered M1B. And regarding PET, greater sensitivity and specificity with regard to metastatic disease. Occult metastatic disease can be detected in up to 24% of cases, selected for curative surgery. So obviously changing therapy from cure to palliation, and really can alter management in up to 40% of patients. So a pretty significant amount of patients will have their management altered because of PET results. Example here, this PET positive left lower lobe primary, and you can see, at least anatomically, there is a little area of sclerosis here in the sacrum on the right, which correlates with an M1b sacral metastasis. Okay, so to summarize, imaging plays an important role in determining lung cancer treatment, whether it's curative or palliative. While it's certainly a lot of us prefer CT of the chest done with contrast, non-enhanced CT of the chest is, through the adrenal glands, is usually sufficient for anatomical imaging, and the role of CT and FDG PET are complementary for TNM lung cancer staging. Okay, so the evaluation question. Okay, which of the following statements is or are true regarding the role of imaging in lung cancer staging? Okay, CT of the chest through the adrenal glands can be formed with or without intravenous contrast. FDG PET is of limited utility in the T staging of the primary mass. Number 3, nodal staging accuracy is improved through the combined use of CT and FDG PET. 4 would be that the first and the third are true, and 5 would be that all 3 are true.